Hello, everybody, and welcome to the Semados Campus Web Seminar for Professionals. My name is Marcio Garcia dos Santos, and I'm part of BEGO Implant Systems Education and Clinical Research team, and I will be the moderator of today's session. First of all, I hope that you and your family are all in good health. And before introducing our speaker, I would like to thank Mrs. Angelica Jacob from BEGO Implant Systems Marketing Department for the organization of this session. The topic today will be the tissue master concept, a new biological concept to optimize implant sites, and the speaker will be Dr. Stefan Neumayer from Germany. Dr. Neumayer studied dentistry at the Julius Maximilians University in Würzburg and was awarded with the Adolf Lübeck Prize. He is a widely recognized specialist in implantology and runs the practice Dr. Neumayer and Partner, which he founded in 1981. There, he looks after a large number of satisfied patients with both simple preventive and highly specialized treatments. In the course of his career, he has received various certificates, like the Master of Science degree in Periodontology and Peri-Implant Therapy awards, and has invented and developed a special treatment method himself, which he shares with the dentist colleagues in international training courses like today. Dr. Neumayer, thanks for accepting the invitation to conduct this session. As always, at the end of the lecture, we will have a question and answer session with the speaker, and you can place your questions in the question box during the whole presentation. I wish us all a very nice time, and I give the words to Dr. Neumayer.
Yes, thank you very much. It is, of course, a big honor and a great pleasure for me that you give me the opportunity to tell you something about a near coincidence which happened some years ago. So I invite you to follow me the pathway which is given by a new concept. It is the tissue master concept. It is a new biological concept to optimize implant sites. Sie müssen das freistellen. Okay. So we have
Just a minute.
Okay. Wait a moment, please. Yeah, just. Okay.
Perfect.
Yes. So, the tissue master concept. Okay. It does not react.
Oh.
Okay. I think when we want to do long-term stable and very aesthetic prosthodontic reconstructions, I think it is necessary that we not only know the harmonic relationships between red and white structures. I think it is very important that we know the functional and structural relationships, especially when we work with natural teeth and implants. It does not react. It does not react. Sorry, they have. Yes, and implants. Okay. So we know exactly what happens when we lose the tooth. Yeah, the situation will be that within some weeks we lose approximately 50% of the height of the buccal lamella, as well as 30 or 40% or more of the alveolar wall. So we have been very happy about the development of augmentative strategies, because now it is possible to preserve or to build up again these normally lost structures. But by all benefits which we could create, let me say some critical aspects when we are doing augmentative strategies. So, for example, we do not talk about a minimally invasive strategy. we talk about a very invasive strategy, and we mention sometimes minimally invasive aspects. Then we have or doing a treatment concept which takes enough time. This is of course, and we also have to recognize that we bear our or burden our patients with a lot of cost, which means that we are not able to give this benefit of augmentation strategies to all our patients. And then we talk about experience, and when we know that we get most of the experience by the trial and error, I think we have to mention that error is not good for our patients. And even the big defect problems, just in a situation where the patients would meet our highest requirement, we are not able to say how is the outcome of our therapy. And later on, really, did we once ask, or mostly ask the patients how they feel when we are doing the third or fourth surgery? So these are aspects. But more than 20 years ago, I made a big mistake. I was planning an intraoral root resection. But anyway, I didn't feel well, so I decided when the patient had got already the anesthesia, that I will take out the tooth and I will make a root resection outside of the mouth, and then I will replant the rest of the root again. So I did, but the situation was that I only could replant a severely compromised rest of the root, only 2 millimeters high, with a broad band of periodontal ligament. I think everybody would have felt the same. I felt a little bit ashamed. I was not happy about my work and I tried to forget it immediately. So the patient came back after 6 years. And you know this, I got really nervous. My heart was running faster. And I said to the patient, hello, how do you feel? I made a surgery on a premolar on the left side. And can I look about the result after 6 years? So the situation was that the patient was laughing to me because I saw nothing. And he said it was not on the right side, it was on the left side. So the same reaction with my heart. I was looking to the left side, but I didn't see also nothing. And then I said, you have had, Stefan, much luck. Okay, be happy and forget all. 10 years later, a patient came into my office. And he told me that the doctor told her that the premolar low in the right side, in the right lower premolar region would be the initiating the pain in the right knee. So she wanted to have an extraction of this tooth. At this moment, I got an idea, because now I remembered what I've done 10 years ago, with the result that the whole volume of the alveolar region was preserved. Now I decided to do an extraction, to do a high resection, and to replant the rest of this tooth with a 2 millimeter broad band of periodontal ligament. So I did. And this was in 2004, and you see this on the X-ray. And then some months later, I saw that the alveolus was completely filled with bone, and it seems that we haven't lost something in the volume as well as the buccal bone lamella. But the situation was that I couldn't find literature about this, the replantation of a 2 millimeter broad band of periodontal ligament with this reaction. So I remember the Nossal when he said there can be no racial diagnosis or improvement in human health without an essential base of having a detailed knowledge of how things work before they become disordered. So I couldn't find any literature. And so I remembered what Andre Schröder, Hubert E. Schröder has told me. The structure and function of the periodontal tissues have been extensively researched. The interaction of their cellular and molecular components to understand and to use for therapies, however, is the aim of future intensive research. So I stopped to mention critical aspects. I think it is better that we look for new strategies. And therefore, I was asking me what we would wish. So when we lose a tooth, then we know exactly that a resorption takes place. And then we get the resorption, and this is the result. And therefore, we need augmentative strategies pre or post this process. But if it could be possible that the information flow in this system could be preserved, then the healing process would run early and could preserve the whole volume. This would be the possibility, or would give us the possibility to insert an implant in a nearly perfect prepared implant bed. So, what is the answer of this question? I think at first we have to talk about a maintenance of the flow of information. We want to preserve the information flow even when the tooth is out. That we are able to do this, I think we have to talk about the biological structures and their functional relationships. So this means that we have to look, for example, not on this picture, showing different situation between the natural tooth as well as the implants. So we have to look at the real function. And this we see in this DVT, and it explains how clearly and strong nature is thinking. This is the real situation where our tooth is anchored in the aperture, for example. And this is the axis, and this is the surface of the root, the bone lamella, and this is the periodontal ligament. But what is the essential part of this? This is a construction of nature which allows us, for example, to that the aperture is only fixed on 4 pilots with the skull or with the basis of our head. And this allows us, for example, that when we are old, even when we have no teeth, we can go and stand just upright. And this is leading to the sound at the outer surface of the skull, and this allows the pneumatization of the maxilla, and therefore we have a possibility that the light construction and nature is doing this in a brilliant way. And when we lose a tooth, for example, by our reversation, and we are doing a replantation of this tooth again, we see that we can preserve the surrounding tissues nearly to 100%. And when, for example, we are doing the extrusion of a tooth, then we see that the adjacent tissues follow this movement nearly up to 100%. But when we are doing before a supracrestal fibrotomy, And then we are doing an extrusion. It seems that we are pulling out the tooth out of the alveolus without following the adjacent tissues. What does this mean? This means that for the information, the periodontal ligament is of course responsible. And this, for example, explains the lamellar preservation technique of Mark Hürzeler and Otto Zur. But we also have to recognize that the supracrestal fiber structure, plays a very important part when we look to the behavior that when we do supracrestal fibrotomy and then the extrusion, that we pull out the tooth out from the alveolus without following the surrounding tissue. So this seems that the supracrestal fiber structure, and we will see, plays a very important role. So the development of new therapeutic concepts on the basis of a new scientific knowledge requires, of course, an intensive examination of the all-overall matter, and thus forms the basis of the tissue master concept. Therefore, we are looking for success parameters. We look for the structural and functional features, the tissue reactions, forces, treatment times, and effort, the process engineering, preserving and regeneration of the oral tissues. What is when we are doing replantation and extrusion? What is with patient's burden? Are there strategic aspects? What is with the evidence? And can we create visions when we get some or have learned some experiences? So at first we want to look to the structural and functional features and up to the process engineering. And I will now invite you to go with me through in a treatment concept where you get the feeling that in the first time in your life, you get the feeling that you work with nature and not against nature. And all what you are doing is accompanied by nature. So at first, the process engineering. Let us look at this very important point. The process engineering is very easy. We do not use magnets in provisionals or screws in provisionals, like when we are doing, for example, osteodestruction. No, we only are using bars and elastic bands, or we are using tension springs in provisional bridges. But we are working with very high forces. We do not talk about centinewton. We do not talk about weeks and months. We talk normally about Newton, 5, 10, 15, up to 20 Newton, and your patients have no pain because we try to bring out a conical shape out from a conical base. So, and when we, for example, are looking for the force introduction, like you see here, we also can improve or increase this force very easy. This is the construction on the left side, and we start with 6.4 Newton. When we take the same elastic band and we change the construction a little bit, we can increase this up to nearly 12 Newton. And when we create a perpendicular introduction of this force, we can increase this force nearly up to 16 Newton. And then we have to look at the tissue reactions. So, at first, of course, to the soft tissues. This is, for example, a clinical case, and we see that the health on the left central incisor, we see a small recession. But when we would do an extraction and we would not take care, the recession would be larger. And if you would know the patient had a high lip line, and then we would create non-aesthetic prosthodontic reconstruction. So in these cases, for example, before we do the extraction or have done the extraction, we do an extrusion of this tooth. And because we work with high forces, not with the unelastic band, with two and very short elastic bands, and this extrusion of a millimeter takes only 8 hours. And then we fix it. So the treatment concept is for the patients really acceptable. So, and then we wait. How we had learned it at the university. We wait for the primary bone answer 4 weeks. And when we wait for the maturation time, then after 10 weeks, we have a new, completely and higher is established mucogingival contour line. So then we look to the hard tissues, because we must know when the bone will follow up this movement. So this was a patient, and we see that there is a fracture on the upper left lateral incisor, and then as we found fracture lines or infracture lines in the rest of the root, so we decided to do an implant prosthodontic reconstruction. But this was in 2007, and so we wanted to learn what will happen when we do extrusion. So now we fixed the broken part again, we shortened it, and we were using elastic bands and moved this tooth within 2 days up nearly to 2 millimeters. And then we were fixing it. As we know how bone healing will run, we know the primary bone healing situation, and then the maturation time of approximately 6 weeks. So we have a time period of approximately 10 weeks. And so we were using the digital volume tomography to look what happens with the buccal bone lamella when we would do an extrusion. So we started on the 24th of April 2007, and 4 weeks later, we also made the DVT. So yes, then when we compare this, we have seen that the buccal bone lamella was 10.72 millimeters high. And 4 weeks later, it was 11 millimeters, 7.37 millimeters. So if we because we were doing an extrusion of approximately 2 millimeters, this was not so much that we can or that we can assign of the height of a gingival margin to the margo alveolaris. But when we were waiting the second period, the maturation of the bone, we have seen that the buccal bone lamella was growing up. And so, because we have done a lot of this analysis, we can say that when we do an extrusion, that after 10 weeks, the buccal bone lamella will up to 90%, 92% follow this movement. So now we can assign to a gingival margin the margo alveolaris 2. This is very important for doing or for minimize, for example, doing flaps to look where the different structures are related, how the different structures are related to. Then what we are interested to is that we look to the preserving and regeneration of the bone. So, for example, the alveolar wall. And there we have had a patient who was smoking and a lot and drinking, so she wanted to get implants to celebrate her 50th anniversary. But I said to her, this is not good that you are doing smoking 50 cigarettes a day. Let's make a bridge work, and we will bring back the lost alveolar volumen with doing extrusion of the central incisor as well as the right lateral incisor. And so we did. This was matching the margo alveolaris with the clinical situation, and we see that this margo alveolaris was below the mucogingival junction. So it took only some days. Then we have brought up these roots in this position. We have equalized the soft tissue, the level of the soft tissue. We have equalized the situation with the surrounding teeth. And then we were waiting and we were measuring how much of bone we could create and what is the volume of this and how long stable this reconstruction or this regeneration would be. This was 10 weeks later, and then we removed the rest of the roots. Look, and when we compare the X-rays, then we see that we have gained a lot of vertical bone. Yes, and we have a little bit improved the periodontal situation on the adjacent left lateral incisor. And when we look to the DVT, we see that we were able, with this poorly rest of the root, nearly to regenerate the whole alveolar. And then we extracted and we made a histological analysis at the University of Regensburg, and we have seen what we have expected before, that the periodontal ligament is the main part when we are doing extrusion, because this histological analysis show no inflammation. It is only stretched periodontal ligament in different colors and histological analysis. And this was in 2010 the prosthodontic result, and this was a situation 6 years later, and this was a situation 8 years later. So when we are doing extrusion of badly compromised teeth, for example, and we create the alveolar bone, and we are widening the attached gingiva, we know or we see that we can create long-term stable results. And this, I think, is very important for not only for our patient, but also is very important for us, because that we can talk with our patient in different situations when we want to do this to create long-term stable clinical results. So then we were looking also to the bones by DVT, and here you see the situation before we have done the extraction of the rest of the root, and we see that when we are doing this a little bit, we get a rounding up of the buccal bone plate. Okay, so but then when we compare, for example, the DVT with from 2010 with the DVT from 2020, and then we see that we can really talk about long-term stable situation. So, for example, when we want to insert later, because if it is necessary, implants, then we have already prepared implant bed. It seems perfectly. So, the role of orthodontic extrusive remodeling in the enhancement of soft and hard tissue profiles. prior to implant placement, a systematic approach to the management of the extraction site defects from Henry and Maurice Salama is a brilliant paper where I learned much. It is clearly defined and it is really worthwhile to read this paper and to now to start with a treatment or a management concept which is less invasive when we have done always surgery or use surgery techniques. So, but when we see what happens, I think that the clinical situations can show us some difficult problems too, and therefore it is necessary that we understand the behavior, that we understand the functional relationships and the information flow in this system. So, because when we want to steer the tissue reaction, which is sometimes necessary, we really have to do exactly this to get a good or very good result. So, one day, a patient came in my office showing this clinical situation. He was asking me how, or if it is possible to preserve this tooth. And he was completely astonished as I said, yes, we can. So at this time, I already got a lot of experience with clinical cases and have already told you that the first time in your life you work with nature and not against nature. So I clearly was looking at this X-ray and I explained him what I want to do. So this is the central part and this is the focus. So now what we see is that at the molar, the premolar, the mesial root, we see there is a pocket and there is a sufficient distance between the bone level as well as the height of the healthy part of the dentin structures. But when we look at the distal side of the premolar, we see that normally we would have made osseo resection to improve or increase the distance between the bone level and the tooth structure level. So this on the molar is okay, but this on the premolar should be the same distance. And so I was remembering what is the difference when we are doing extrusion with or without a fibrotomy. So look, I remembered the important role which the supracrystal fiber structure, yes, will play in this system. So when we are doing a fibrotomy and we are doing the extrusion, we pull out the tooth from the alveolus. And this I decided here to do. I decided to do a selective fibrotomy, which allows me a selective steering of the regeneration process. So I can regenerate the tooth surrounding soft and hard tissues rather exactly and can so create a natural scallop. So look, the only thing what we did was a fibrotomy in this area. Because when we look to the other areas, which are not so much in focus, we see that there are periodontal, no healthy situation, a loss of periodontal tissues. So then we did the extrusion within days. So the premolar we extruded in 4 days, from here to here. The molar took a little bit more time. So we were doing the extrusion from here to here in 12 days. And then we were looking to this after 8 weeks. This was the result. Coming from here with the bone level and ending here. And we have seen that not only here we have got or won some bone, there was also a changement in the adjacent teeth areas. So we see a higher bone level between the molars. We see that the slightly opened bifurcation was completely closed. And this was the clinical result. And this was the X-ray 4 years later. So I did right that I told him it is possible to preserve these teeth. And the only thing what I did was that I did an extrusion and I made a difference at the premolar, at the distal side, where I did a fibrotomy to avoid the following up of the adjacent tissues. But what does the expression steering the tissue reaction also mean? And this was in the beginning. And you remember what I have told you when I listened, or what I heard when I was listening Hubert E. Schröder, what he's telling me about the relationships and the functional interaction of the tissues. We know already very, very good. So, for example, this is a situation with a broken tooth. We have seen that it is critical, and the situation is just not easy, and the aesthetic is also not very good because it looks asymmetrical. So I decided to do an extrusion of this tooth, which was broken rather deep. We do an extrusion. So we are improving the bone or implant bed. And then when we are doing the extraction, so in comparison, look, we have now a symmetrical situation. I think this gives our eye now a feeling, a quite a different situation and a quite different result when we have symmetrical situations created. This is the measuring of the bone. So we see that the biological width of 2.5 millimeters we can find with this implant bed probe. Yeah, we see that we have preserved the natural bow of the alveolar volume. Yes, no flattening, no recession, nothing. Look, we see very healthy structures, soft tissue structure, and we see also that the bone has followed after extrusion and has created a very nice implant bed so that we could insert a healthy implant in a healthy situation. And this is the result. Only the movement, or that we placed the gingival margin at the left central incisor, just in the same height, gives us a feeling of symmetricity and leads to reaction in our physiological situation. But what does steering the tissue reaction also mean? Because when we want to do good or long-term stable reconstructions, at this time we have to learn, for example, to ask and answer the question, what is the relationship between bone and soft tissue? Is it true that the biological width is a natural concept where we can expect, for example, when we do reconstruction, that it is also a stable situation? So what does this mean? This patient came approximately, I think, about 9 years ago in our practice, and she had severe periodontal problems on the left, the central and lateral incisor. Look, We have seen pockets of 15, 16, and up to 18 millimeters. And normally I would have done an extraction before I got the information about the tissue monster concept or created it. So I said to the lady, no, we do not do the extraction. We do an extrusion. And then we will see how the bone will follow. And if it is possible to steer the way of following which the bone will do. So look, we were cutting this piece, then we were using elastic bands, and we were extruding this. So we have to do a very high extrusion because the interbone defects were very deep and the pockets. So, and what we have seen is that the buccal, not the bone, but the buccal attached gingiva, as well as the inner epithelium, will follow this movement very, very much. So we have created this situation. And when this is the gingival margin and the biological width is a functional relationship, this means that the bone will follow up the movement of the margo gingivalis in a biological width. We could expect the margo alveolaris in this situation. So if this would happen, we had to extract after 10 or 12 weeks the rest of the root, and we had to remove, we had to do osteoresection. But this is not the sense of my therapeutical concept. So when a margo gingivalis is related to a margo alveolaris, it also could be that the following of the bone of the margo alveolaris is also related to the margo gingivalis. This means that the biological width is really a fundamental law. And what I did is I was using the electrotome and created a new margo gingivalis. And this was the situation. So then we were looking by DVTs to this movement of the bone. On the left side, you see the movement of the left central incisor in one day. So then, after some days, when we have seen this tissue reaction, we were fixing it. And when we are looking now to the buccal bone lamella or to the margo alveolaris, we can compare the situation with, on the right side, with the situation which we have established. Because this is the borderline of the composite filling. This is the margo gingivalis. And this is the margo alveolaris. And this is the distance of the biological width. It was up to 2.5 millimeters. What does this mean? When we do extrusion and we are defining a new margo gingivalis, the bone will follow in a distance of the biological width this decision. He only went up this small part and healed. This, I think, is very important because now we are able from outside looking to define the margogingivalis as well as the position of the margo alveolaris. So, what is the conclusion of these experiences? The first is that high forces initiate short treatment times. We talk about days and then we fix it. It is up to us to do the fixation in an aesthetic way, of course, but undermining the healing of the bone will follow. So the soft tissue reaction is much faster than bone, meaning giving us a chance to do the movement of the roots in a very fast way, and then it is followed by the bone in the distance of the biological width. And which we have seen is also very important, what we have seen. We have seen that the predictable results, according to the classic orthodontic treatment concepts, can be created, and we talk really about long-term stable regeneration. So when we have got this experience of preserving and regeneration and the steering process, I come back to the replantation and to the extrusion. So I remembered my experience when I had replanted a poorly rest of the root, or the results which I've seen with my patients in the lower jaw when I replanted the rest of the crown with an adjacent or adherent 2 mm broad band of ligament. What has happened? So when I have seen this picture or clinical situation in the mouth of a patient, I see that there has taken place resorption in all these areas where the patient had lost a tooth. But even in these areas with badly destroyed teeth, we see that no resorption has taken place. Even the bifurcation, not the trifurcation, we see was never no longer in function. But we have it seems no loss of hard and soft tissue, alveolar tissues. So when I look at the orthopantomogram of this patient, it was my idea that I could, for example, do an extraction of these poorly rests of the roots. I could fill, for example, the root channel, and I could remove the inflammation at the apex, and then perhaps by implantation to give back the function to the supracrestal fiber structure. What does this mean? So when we take out the tooth, it could be possible that the information flow could be preserved and the resorption cannot take place. So this means that when we use the supracrestal fiber structure as the most important impulse relating structure, then we could initiate or preserve the flow of information and so avoid the resorption process. Not only to avoid the resorption process, also to give nature the possibility to come from periodontal arterioles, the nutrition bone, to an adult bone with Haber's and Volkmann's channels. Look, And this would mean that we would have created a very good implant bed, and we can insert and so have the insert an implant and have so the best chance for a long-term stable prosthodontic reconstruction in the interest of our patient. Okay. So this is, it seemed for me at first, the miracle. You see a 2 millimeter broad, yeah, and a segment of a premolar. You see the periodontal ligament. Yes, of course, a rupture when we had done the extraction. Yes, we no longer were using periotomes. Yes, because we want to have the ruptured rest of the periodontal ligament on the root surface. Yes, of course. And as we are talking about the biological width, it is only necessary to have, this was my experience, of a 2 millimeter height of this periodontal ligament. So now we talk about the extraction of the tooth. We talk about a high resection and the reimplantation of a root segment. And this patient came in 2005 or 2000, yes, in my office. And she had problems with the premolar on the upper left side. There were inflammation, a lot of caries we see, and she wanted to do again a complete reconstruction of the upper and lower jaw. So I told her that I don't want to make an augmentation. I will do the extraction. I will do a replantation of a root segment, and then we can place implants. So we did the extraction, and then we replanted this rest of the roots. These roots had at the basis a 2 millimeter broad band. I was bringing this in position. I did the surgery without any cut. I removed the inflammation and the processes over the open alveolus, and then I was replanting this. And this was 13 or 14 years ago, before now or ago. So I had no much experience, and therefore I told the patient she should come back in 5 months. Exactly, she did this. And then I have seen this. I was a little bit astonished or ashamed because I saw at the apex translucent area. But when I was asking the patient, she told me that 6 weeks before the composite splinting was broken. This could explain the situation at below the rest of the root and the widened periodontal situation. But when we were comparing the height of the interdental bone level, we have seen that there has happened nothing. So we could preserve this level completely. And when we are looking to the buccal bone lamella and to the situation we have seen, that we have removed the inflamed area, but the volume was completely filled up with healthy bone. And then we decided to insert an implant. And we decided also to ask the question, how long-term stable is the bone? So we started in 2006, in June, and exactly 5 months later, the patient came into my practice again. And we have seen this situation. And then we inserted an implant 9 days later. And now we made the control. This is the control, I think 13, wait a moment, yes, the situation on the 17th of October 2019. So we talk now about 13 years. Yes.
Wait.
13 years. Okay? Then we talk about extraction, high resection, and replantation of root segments. We also can look to the patient, I've shown you before, and which has caused me to think about a lot about the functional relationship in the dental alveolar system. And of course, we were also asking the question how long-term stable this situation is. So you see that we have placed in 2006 an implant, we were controlling this. And when we are comparing the shape of the bone before doing the implantation, and 7 years later, and now when we are comparing or controlling this over a period of 15 years, I think we can talk about long-term stable reconstruction of the alveolus area. So we had done nothing without doing replantation of a 2 millimeter broad band of periodontal ligament into the supracrestal fiber structure. And when we look to the surrounding soft tissue and compare these clinical pictures, the latest was done with to show the difference of between the mucosa and mucosal solution, yes, to show the difference between the attached gingiva and the mucosa. Then we see, and we can compare this, that the situation was stable over 15 years. I think this is something where we can start to talk about long-term stable reconstructions and regenerations and restorations. So now we were focusing the extraction, high resection, replantation of root segments more and more. Because now we started to answer a lot of questions. Because we got a lot of experiences. I was asking the university, Professor Neukam, if it is allowed. I was asking the ethic commission at the University of Freiburg. So we did this and we got the permission. So this is a clinical case, which is also very interesting, where we have learned much. So she has a palatal abscess. You see the inflamed situation. This is a situation where we have marked the borderline between the mucosa and the attached gingiva with the glucose solution, yes. And then we had to do the extraction. Here was the palatal abscess, yes. We have taken out the epithelium-coated soft tissue, yes, of course. And then we were deciding what segments we want to replant. As we were looking to the buccal area, to the buccal roots, we see that there were a lot of denudation. This means that we could not build a segment with completely surrounding periodontal ligament, and so unable for the replantation. But when we were looking to the palatal root, we have seen that we can create 3 segments which we can replant. Of course, we were closing the root channel, you see in the central, and we placed the biggest one at the palatal side, and the other 2 we were replacing buccally. So the question was, in addition to the premolar, what will happen with the bone, or what will the body do with the coverage of the bone? So we were we got the permission from the patient to follow this healing process. And this was the situation 18 months later. The patient became pregnant and didn't want to have an implantation. I was asking her if she would allow us, not to do X-rays, of course, no, to make impressions, that we could find out what happens during the healing period. How stable will be the volume, how stable will be the buccal lamella, and so on. So, this was the situation on the 5th November 2011. And we said to the computer that if there is a changement more than 0.5 millimeter, please create on the model a red dot. This was 3 months later. This was 9 months later, and the segments were still in position, but nothing happened. And this was 15 months later. But we never have seen a dot. It seemed similar from the beginning to the end. These were the lines, and you see that the changements were minimally, perhaps a little related to the ratio of powder and water of the alginate. And this, what you see here, is the rest of the broken tooth before extraction. And on the palatal side, you see the swollen palatal mucosa, yes, which disappeared when we had taken out the root. So this now was the X-ray situation. And then when you look to the right side, you see that the sinus has stayed in the same shape like before. This is something I really now cannot completely explain. But when we do the replantation of a root segment in the upper area or in the area where the sinus we normally have or can see, we never have seen an expansion of the sinus, meaning that the volume of the bone in height, also in wideness, is preserved, and so it is easy for us to insert an implant. So we cut the trabecular shape, then we insert the implant. We are using a provisional which we screw on, so we create a very nice implant bed, which is done by this way much more stable. There is no pressed interstitial liquid, nothing. This has been growing up, and when you are doing an expression, you have 15-20 minute time till this shape does change a little bit. And so the technician can make a nice and not symmetric, just related to the shape of the gingiva, the apical part of the cervical part of the crown. And so we have less problems when we do the cementation. And when we look to the comparison of the left and on the right side, you see on the right side the first premolar, the first molar, and this is the implant. I think for this we are due to. We have to give back the patient, yes, personality, integrity back, and this is main basis for our work, to do a good work. So when we compare now the mucogingival borderline, yes, then we see that this is stable. Yeah, the shape of this region is the same. So this thing is also a very good sign, because we preserve also these structures before changement. This is the clinical situation of the prosthodontic reconstruction with an implant. and therefore we have to ask for the bone quality. Yes, this is the bone and molar region, and this is, we know, Lake Mansard or Mish. This is a class 3. This means we have trabecular bone and fat cells. This was the patient, and we see healthy structures, and we see also a healthy bone. But it is important that we know how what is the structure of the bone. This, I think, is very important. Okay. And when we go into the canine area, then we see that this is a much more denser bone, so we have to drill and we have to use screws. Yes, this is of course. And we see also a healthy bone. Yes. And therefore, we have now analyzed 12 patients which underwent a tooth extraction followed by immediate replantation of a transverse root segment. Root discs were removed after 14 weeks. Histological analysis showed high quality density and vitality of the regenerated bone. Radiological analysis revealed preservation of the alveolar dimension between 92 and 95%. Yes, these results we want to publish. Yes, we are just pre-path. And this study proves the concept of alveolar ridge preservation by replanting root segments as a safe and reliable alternative to current methods. Yeah. And when we now look to the possibility, then we will see what we also can do. So now we have done the replantation. We can, over the open alveolus, remove the apical region. But what we are also showing interest is what will we do or can we do when we do extrusion of a replanted root segment. Does only follow the soft tissue, this movement, or is the relationship between margo gingivalis and margo alveolaris really very high? Then we could expect that when we are doing the extrusion of a root segment, we also can extrude the bone, the buccal bone, the bone margin. This would be give us the possibility to place an implant in a higher and so more aesthetic position. This was a patient who came and he got an endodontic treatment, and the post that he heard a crack. You see the apical reaction. It was not possible to remove this, so we decided to do an extraction, a high resection, a replantation, and I will show you now what has happened. So this is the situation in the mouse. From aesthetic point of view, we would expect that the height of the margo gingivalis at the right lateral incisor should be the same after replantation, because then we have the feeling that this is a very symmetrical and an aesthetic can fulfill approach. Okay, so we did the extraction. This was the apical part with the periodontal ligament. We replanted this, and then we were waiting some days. Normally we wait 10 days, and then we did an extrusion within 1 day and fixed this segment. So the question we want to have answered was, does this movement of the gingival margin also follow the margo alveolaris? And now we make the same. This is a situation where we're starting form after replantation. Then we did an extrusion. We did the extrusion above the margo alveolaris. So then we could be able to answer also another question. What will happen? Will the connective tissue grow growing into the central part, undermining the segment? Or is this like a guided tissue regeneration, that the bone will follow up this movement. Look, and this is not Photoshop. We have seen that when we do the extrusion of the segment, the bone will follow this movement. And now we were looking at this, we could show this, we could feel it with the probe. We inserted an implant and we were controlling the situation from outside. So starting from February 2008, we came to February 2016, and we focused this area. We see the stippling. So we know that the buccal bone lamella must be below, yes. And we could also prove this and document this. So now we can look on these results after a period of 12 years. So also in the aperture, also when we are doing the extrusion of segments, we can talk start to talk about long-term stable reconstructions. And I think in this situation, the new definition of attached gingiva around teeth and implants in healthy and diseased site of Dennis Tartano is a paper which actually came out this year and is very interesting and giving us the information how we would have to steer, as well as how we can decide and discuss the different situations. The extraction and the replantation of root segments also was done in the lower jaw. We have seen this. We were measuring this so that we can compare. And we were also always looking to the long-term stability and to the results in the coverage of the soft tissue, as well as in the volume and the preservation of the hard tissues. So we were fixing this at this time in this way. We never do this, but it was in the beginning. It was in 2008. And then we wanted to regenerate this bone loss. And so we were looking to the bifurcation. Will the bone in this area also follow the movement of the roots? So we did the extrusion, and in the situation here of the distal root a little bit higher than in the mesial part. Then we were doing the fixation for 8 weeks, and we made a new X-ray. The first, what we have seen is that we have preserved the quadrangular profile of this area, meaning that we can do a very nice prosthodontic reconstruction looking naturally. The second was that we completely have regenerated also the bone between the two roots, nearly a little bit more and above. So to insert an implant, I had to take out the central part between these roots of the bone. And we have created a broad band of attached gingiva. Then we inserted the implant. And I have had to take out this, but we see on the left picture a very healthy bone. Now we can insert or we can now screw on an abutment made of titanium and glued to lithium disilicate, which we close, and we can close with the bonding technique. And then we can use this anywhere, what we want to do. But the most important thing is that we can create a long-term stable situation for the patient. This means we have to look on the shape, we have to look on the structure quality of the soft tissues, the stability of the bone. Wait a moment. Wait a moment. Yes, wunderbar, passt. Yes, we are back. Okay. And this is the clinical situation. So when we now look to the X-ray, we see always the same. When we have replanted a segment and when we have done extrusion of these segments, we also improve afflicted areas. So we, at the mesial part, we brought back the height of the bone back to the former situation. And when we were looking on the DVTs, we see that even in the lower jaw, we have the same result. We can talk about long-term stable bone situation, and we can also look in this situation on a healthy bone implant situation. And now we come to the end when we look to these clinical cases: extraction, resection, replantation, and translation. Because this is also an aspect for the future. When we look to this situation, we see that we have a problem in the bifurcation. Really, this patient had a problem. Because when we look to this, we have seen that the post in the distal root has created a longitudinal fracture of this root. So we had a resorption, you see this. Epithelium-coated soft tissue has grown in. The buccal bone lamella was nearly completely resorbed. We had to take away this. And then we decided to replant two different segments. So in the mesial, we were using the center, the coronal part, the cervical part of the root as an orthograde segment, and in the distal part we were using the rest of the root as a horizontal segment. Of course, we closed the root channel with an adhesive cement. Okay, and this was the situation. Also, we do this construction, or did this construction not a long time, because if the patient is biting on this, this will change the position of the segments. So, but when we look here in this situation, and this was stable, then we see the position of the segments. The first was orthograde, and the second was horizontal. And then we were waiting 1 month, and then we did an extrusion. Is there a difference between these different root segments? In the movement of the surrounding soft tissue, we can say no. When we look to the X-ray and we do the extrusion, and then we fix it, and we are looking to the gain of bone, we can also say no. So within 8 weeks, look, we have regenerated this much amount or high amount of bone, preserving the surrounding soft tissues. We could insert an implant, and when we look 8 weeks later, starting with the 15th of July 2010 to the 16th of September, also 2010, we see in the comparison of these two DVDs that over this period of time of 2 months, we have regenerated the situation nearly completely. And when we look to evidence, now we can make a conclusion. The replantation and extrusion of root segments allow a predictable preservation as well as an enormous regeneration of the alveolar tissues. The methods are minimally invasive, cost-reductive, time-saving, and reduces patient's burden. Latest after 3 months, an implant can be inserted in a healthy bone structure. The and regenerated alveolar tissues show long-term stability. The clinical results can be compared by any means to augmentation techniques. Yes, of course, Further studies, and we are working very hard, are necessary to prove the results of these pilot studies and to point out the full potential of this treatment concept. We have a lot of options. Classic orthodontists, extrusion of teeth with high forces, Professor Wissen. Think on Henry and Maurice Zalama. The implantation of root segments, orthograde and horizontal. Extrusion of root segments, translation of root segments, transposition of root segments, combination with surgical techniques. And visions? Yes, for you I have visions. When you see this picture, you now know that the premolar is really no problem to preserve. If you want to improve for a prosthodontic reconstructions, the shape of the rest of the root, yes, if a rule principle, then do a little bit the extrusion. And when you look to the molar area, you can decide what you are doing. Perhaps you are doing a perfect endodontic treatment, and the reaction in the area of the bifurcation will disappear, and in the apex, or you decide to insert segments, for example, as in order to create a very nice implant. If you are doing the decision or you decide to do this way, then I think it is necessary that you can preserve the volume like you see on the picture. And this is very important. And when you see something like this, and you see in the X-ray this, think about what extrusion and replantation can create. And you have now this situation. Yes, if you want to have more further information, do not hesitate to contact me. This is our address. I thank you very much that you have listening to me. I hope it was not too long and you got some ideas. Thank you very much.
Thank you, Dr. Neumeier. What a very beautiful, very nice concept, very interesting concept, and clear, very well explained to the colleagues. So I believe we have around 130 persons with us, and I believe yeah, all of them got the same impression than I. That was very clear explained. So thank you very much for your contribution. You can still place your questions in our question box. We have one from Dr. Im saying thank you very much for the wonderful presentation. I was just wondering, have Dr. Stefan came across any external inflammatory resorption following reimplantation of extraction roots into the socket? Is there any chance of more destruction if it happens to be external inflammatory resorption? Thank you.
Sorry, Matthew, I did not understand the
question of the colleague. As I understood, I just read it one-to-one. If you face external inflammatory resorption following reimplantation of extracted roots into the socket.
Yes. So look, this is a very interesting question. Yes, thank you that I got the chance to answer on this. Yes, this is really something because it is that we have to focus two aspects. When we have an external resorption, yes, this can be caused, for example, by the tooth structure. This can also be caused by the body when he starts and to afflict the root. So what will happen? In some situation, when you have this situation, then you get an ankylosis. But we have several situations and several clinical cases. We cracked this ankylosis, and then you crack it, and then you have to cut the apex. This area where the resorption has taken place, you have in this special case to remove. So you take a burr and remove the apical resorption area. Then I think this is enough. You can do the replantation, and then you can do extrusion. We have seen that in this situation, the process stops because the counterpart of the reaction of in the bone, yes, has been is no longer still in place. Yes.
Okay, thank you very much. Another question, what disinfectant protocols you follow before replacing the root segment?
The situation, look, is of course when you have root filling material, you have good aperture points, you have splitters of amalgam and so on. Yes, of course, you have to remove. I think it is not good idea to let them in place. Okay. The second part is that the only important thing is that you replant a 2 millimeter broad band of periodontal ligament. That's all. And you will see that the body by itself will heal this without any loss of volume. So this publication we are now doing, yes, it's really pre-pub, yes, shows that up to 95%. And when we are doing, for example, a little extrusion, we come up to 100%. Yes, the body by himself is taking care for the volume, because the information of the volume of the alveolar area is not based in the bone, it is fixed in the supracrestal fiber structure. And when you are replanting a segment, it's very easy. Yes, you bring this back, and this causes a maintenance of the flow of information. And then you will see that within some weeks, the bone or this defect will fully filled up with healthy bone.
Thank you very much. You already talked about it, but since we received once again from the colleague a question regarding reimplantation. Can reimplantation of teeth cause ankylosis?
No, no. Look, if you are doing a replantation and you have removed the periodontal ligament, yes, then you will see that this can create ankylosis. But it seems, and this is one point of view we want to focus in the next years very, very intensively, is that the periodontal ligament is showing a quite, or is creating a quite different behavior of the body. You don't get an ankylosis.
Thank you again. After the reimplantation of the tooth segment, of the root segment, when can we start with the extrusion? Also, how many teeth are used for anchorage?
Okay, so when we are doing a replantation of a segment, the segment you have seen has a height of 2 millimeters. Andreas Filippi has shown that if you have a tooth, an avulsed tooth, and you bring this tooth back after 4 to 6 days, the periodontal ligament will be healed. So normally you should wait 6 days. But look, in some situation, yes, the healing is not running so good. The patient has diabetes. The patient is taking some medicine, yes. So we normally wait 10 days and then we do extrusion. Of course, not with very high forces, because then we use softer forces, yes, and we do the extrusion, for example, for 1 millimeter or 2 millimeters, and then we fix, in order to improve the volume and to improve the height of the implant and so on. This is the situation. Wait 10 days, then extrude. So, how many teeth do you need? So, for example, you have lost a molar, then you bond a little bit on this information I can give to my colleagues when they send me their email address. Yes, we can also create a chat room where we can talk about this. We in Germany, for example, and in Russia, as well as in Italy, and now in Switzerland, we are doing training courses. Yes, but in Corona times now, we did this online. This is also possible because this is very easy. And normally you need two teeth, yes, yeah. And if you have only, for example, a molar, and you have this, you can use provisional implant. You screw in, then you do extrusion, you fix it, and when it is fixed and it is healed in 6 weeks, then you take out the provisional, and then you can insert the perfect implant.
Perfect. Thank you very much, Dr. Neumeier. After extraction, it's compulsory to do an RCT for crown and some root portion.
What do you mean?
This I also asked the colleague, what do you mean with the RCT here? So while we wait for this, Dr. Sutariaya,
a three-dimensional X-ray.
I don't know if he means the tomography here, but if he can ask again and we go for another question. Scaling and root planning of the replanted tooth, it is not necessary to do scaling and root planning, and
No.
only 2 millimeters of periodontal ligament is enough?
Yes, because the information, it is no big problem if you use a segment of 3 millimeters. Do you understand? But this shows also that the most important role in this system, this is done by the supracrestal fiber structure. And when you move the supracrestal fiber structure, and therefore 2-3 millimeter should the segment be in the height, and you move this, then you get the following reaction. The following reaction is that the bone will grow up in this direction.
Thank you.
Yes.
We have some congratulations. Our colleague from the International Sales Department, how flexig, eine tolle und sehr interessante Präsentation. So very interesting presentation. Our friend Abdullah Arif, thank you, doctor. Also, thank you, doctor, from Dr. Abdelmonen. Thank you, Dr. Stefan, from Dr. Abdullah Arif. For from our distributor in the Emirates, Mr. Virendra Shukla, he's always here with us. Thank you, Dr. Stefan. Very valuable information. So lots of positive feedback. Dr. Narayan, very interesting approach. The biological rationale is so sound, most impressive. I cannot wait to put it in my clinical practice. Very interesting, Dr. Naela, very interesting. Thank you very much. I have one more question here. What about the Newton's third law, which says to every action has equal and opposite reaction? So an extraction force will have an intrusion force on the anchorage teeth.
Okay, So at first, Matthew, I want to answer the question now. Randomized control study.
The randomized control
Yes.
studies. Okay. Yeah.
Randomized control study. So look, I think in this situation, it is at first necessary to show my colleagues what is possible, because we changed our strategy completely. Yes, and I invite my colleagues and think about, please, before you do an extraction of a tooth, make extrusion. Close your eyes, wait 4 to 6 weeks, and when you open your eyes, you will completely astonished. So this is one experience I got. And really, the first time in the life, you work with nature and not against nature. And this is a big difference. You are the tissue master, and you will initiate and will give the body the information where it has to go to. So, and now to the other questions. The intrusion, of course, when you are doing an extrusion, for example, you want to do an extrusion of a molar with very long roots. And now you are lasting the neighbor teeth with intrusive forces. But look, this is a big difference. When we do intrusion, we know that if you want to do intrusion, then you have to use very low forces, because intrusion means that the structures below have to be resorbed and modified. And therefore it is necessary that the blood flow as a liquid flow will be maintained. What are we doing when we are using very high forces? We are pressing the neighbor teeth into the alveolus. So we create a stasis. Yes, so stasis, this means there is a less blood flow, less resorption, there is happening nothing for a period of time of 30 up to 40 days. In this time, undermining resorption takes place. But when you look to the time you need for the extrusion even of a molar, we talk about at the maximum of 10 days or 14 days, then all is over. So we have never seen a problem with intrusion.
Thank you very much. Dr. Andrada Palamaru from Romania also send you congratulations. Thank you so much from Romania. And comes the question also from Dr. Ka Yim and Dr. Narayan, which is, if the extracted tooth was not endodontically treated before, it is necessary to do the treatment before the reimplantation?
Okay. Look, these cases, many of these cases, they have been or are 10, 12, or 15 years old. At this time, we were starting. When we, for example, do a replantation of a segment, then it is necessary that you close the root channel. Yes? So what we are doing is, when we do the replantation of a root segment, we take it out, we prepare with the burr a little bit, no endodontic treatment, the root channel, then we fill in adhesive cement, light curing, yes, and then you can replant this. When we do extrusion of a tooth, then we have seen we do not do a root filling. We remove, for example, the inflamed pulp or rest of the pulp, and then we are injecting, we are calcium hydroxide. And now think about, when you are doing the extrusion of this tooth, in 14 days, the apex is 12 millimeter higher. Do you understand? So you have no infection in the apex area because there is no root and the apex. The root is already after this times 12 millimeter higher. So the apex is in the position 2 millimeters below the soft tissue coverage.
Thank you very much. Dr. Sok from Cambodia, sending congratulations to the nice presentation, very informative presentation. No hesitation to try in Cambodia. We have two more questions, Professor. Interesting presentation. Did you encounter any infection after reimplantation of the tooth segment?
No. No. So when we have an inflamed area in the apex, of course, we remove this. Then we replant a segment. This segment is made of dentine, is surrounded by a band of a periodontal ligament, and this and the root channel is prepared and closed with an adhesive cement. So this means, and this is astonishing, or this initiates, so it seems, that the body immediately starts up to grow on this ruptured periodontal ligament. And in 5 days or 6 days later, it is perfect in position, and you see that nothing has happened with resorption and so on. This is sometimes the miracle, yes, which makes it so interesting that we are looking at this, and we actually are not only planning a clinical study, a controlled randomized study, we also are doing actually the planning for a multi-center study, because not only the University of Hamburg, Eppendorf, also the Charité with Dr. Maria Brunke and Professor Florian Boyer, also the University of Aachen with Professor Reich and Professor Wohlfahrt, the University of Greifswald with Professor Mund, as well as the University of Düsseldorf already had started. And there are many colleagues, for example, in Russia. We have now started with Switzerland, and in Vienna there is a group already was starting. So you see, and we want to bring together these different groups so that we can really bring up very safe, publish very safe papers. And you see, we are really only the reimplantation of a root segment, yes, causes the preservation of the alveolar volume from 92 to 95%. I think this is an amazing result.
Amazing number. More congratulations, Dr. Azad. Dr. Azad, thanks for the good presentation. Dr. Hopali, thank you very much for the interesting concept. Dr. Ahmed from Sudan, thank you for the excellent and informative presentation from Sudan. Excellent concept, Dr. Pankaj. I have two more questions. Post-treatment instructions.
Post-treatment instructions, yes.
Yeah.
Okay, this is rather simple. We were doing several trials. The most important thing you have to be in fear of is the tongue. Because the patient wants to know, is the segment still in place? Yes? So what psychologists give us the advice? Please use a foil. Yes? This foil is you bring it above the segment, and you say to the patient, let it in place 5 days. The patient forgets to control with the tongue. Is the segment in place? Is the still there? And so on. Really, this is the risk. And after 5 days, the segment is already healed in. And it's the same with immediate implantation with solid body implants. Yes, this is the same problem with the tongue. So we now only do this, and I invite Marcio, all my colleagues who are interested, go to this or send me your questions or your clinical cases. It is rather easy for me. We can create a chat. I can provide you with a guidance to there you can start. This is no problem.
Thank you very much, Dr. Neumeier. I have a last question from the Philippines. How many months you can remove the whole root? So how many months probably to remove in average a root, no? And how many times did you make adjust from Dr. Levy from the Philippines?
So look, the big difference to the classic orthodontic treatment is this we have proven. We have more than 600 clinical cases under control. When you are doing an extrusion, then do this with high forces. And if you lift up the root for 1 centimeter and you fix it, you, and we could show, can create the same result when, like you get when you are doing classic orthodontic treatment. This is one of the most remarkable results we got. That high forces initiate short treatment times. In 10 days, 10 millimeter. The soft tissue is following immediately. No recession, you are stretching, nothing. Who is interested, you can send me your email address, I send you clinical cases. Yes, and we can discuss, this is no problem. Yeah, we can talk about this by email, we can talk about by a chat, this is really no problem. But this was the most astonishing thing for us. And when you compare this, you also have to compare the difference in treating a patient. With classic orthodontic concepts, for 1 centimeter, you need approximately 4 to 6 months, because the philosophy is quite different. I'm invited to give a lecture at the Orthodontic Society about this problem. So, and we have seen that when you are doing the extrusion with high forces in a short time, you stretch the soft tissue and undermining. The bone will follow up this direction completely. This is really amazing and gives you as a dentist the possibility that you are doing this extrusion, then you fix it, you make an aesthetic coverage, yes, and undermining regeneration process of the bone will take place. There is a lot of option for the future because we are focusing, for example, PRF, platelet-rich fibrin, yes. So stem cells, yeah. There is a lot in this because the information is really sometimes crazy, and this is something we started to discover. Yes, and this is a so wide field, and you know that when you are doing this, you always are stopped if you have missed success. But it is so interesting, and this is the reason that I can tell you, when you work in this way, nature will help you. What you are doing is it will follow by a positive answer of the nature. It's like an open box.
Dr. Neumeier, thank you so much. We could stay for hours and hours talking about the concept. We would be a pleasure if we can program another lecture review, another online seminar review.
Of course.
In the name of BEGO Implant Systems, now the international sales department, yeah, I would like to thank you. And we already saw feedbacks from several countries, so it was really a fantastic time with you. So thank you very much.
Yes, thank you very much, Marcio. Yes, and of course, thank you very much, my dear colleagues. Do not hesitate to contact me. Yes, it is. It would be very nice to spread this philosophy, and it is really easy. We can help you. We have prepared so much, and we will start in 2 months with an online training course. Yes, because the questions are starting up and become more and more. Yes, it was a pleasure for me.
It becomes a snowball. So, but this is fantastic. So to all the two that attended to us today, thank you very much. We are back now after the summer vacation. We are back with the next web seminar with you. So thank you very much and have a nice day. Thank you.
The same with you. Thank you very much.
Bye.
Bye.